Dr. Darren Russell, who's really from Melbourne originally, but is the Director of Sexual Health in Cairns. And Darren's going to talk to us about screening for HSV in HIV patients.
Thanks, Suzanne, and thanks, Dominic, for introducing the topic so well for me. There are recommendations and guidelines that are being developed virtually as we speak for screening for HSV2. And these were some guidelines that were recommended, came out of a meeting of folk in California a couple of years ago and have just been recently published. And they recommended that we use herpes serological testing, to assist in clinical diagnosis. And for those at high risk of STDs or HIV who are motivated to reduce their risk behaviour, and for those with HSV2 infected sexual partners, and to all HIV-infected patients, which is the important part of this talk. There are some international recommendations that have been put forward by the International Herpes Management Forum, our parent organisation, and they recommend that HIV-positive people should be serologically tested for HSV2 infection and counselled about the clinical and public health implications of that, and that through testing and counselling and by prevention of acquisition, and with herpes treatment and antivirals suppression, HSV2 should be targeted as a modifiable risk factor for HIV acquisition. So there's a lot of caveats in there. So what do we know about HSV and HIV and their interactions? We've certainly heard a bit from Connie Kellum here, and we'll hear more from her throughout the ASHM conference. But we know that HSV infection increases the risk of acquiring HIV. HSV2 increases the HIV viral load, albeit by a small amount. HSV2 increases the genital shedding of HIV. HIV increases the frequency of recurrences of symptomatic HSV, particularly for those with a lower CD4 cell count. And HIV increases the frequency and titer of asymptomatic HSV shedding. So there is quite a lot of interaction between these two viruses. We also know from Adrian Mindell's work and others that the seroprevalence in Australia is about 12% for adults, and a little study we did in Melbourne, which Suzanne Garland and I worked on, suggested that 28% of HIV antibody negative gay men and 61% of HIV positive gay men in Melbourne were found to be HSV2 seropositive. And this is actually very similar to the data that's come out of the HIM study as well. It's not all that dissimilar. Of all those people, 70% were unaware that they carried HSV2. So the only way we're going to diagnose HSV2 in these individuals with HIV and those without HIV, but who could be at risk of it, is through serological testing. The HSV2 and HIV interaction, we know that when it comes to HIV acquisition, it's consistent with the biology of HSV2 reactivation, that you get destruction of epithelial cells and recruitment of activated CD4 cells to the area. And meta-analysis of studies, this was carried out by Freeman et al. And published in AIDS this year, showed that there was a threefold increase for both men and women in the risk of acquiring HIV if they were HSV2 seroprevalent. So if someone has HSV2 antibodies, they're at a threefold risk of acquiring HIV. And this is from Tom Quinn's work in the Rakai study, that showed that the probability of HIV acquisition per sex act had more to do with whether or not someone had seroprevalent HSV2 than the actual viral load, the HIV viral load. And I think that's a very important slide that shows, once again, the interaction between HIV and HSV. Connie Kellum's also spoken to us about population attributable risk, and it's possible that 38 to 60% of sexually transmitted HIV infections could be attributable to HSV2 in women, and some 8 to 49% in men. That's again from Freeman's paper. So, what about gay men in Australia? Because we know that that is the population most at risk of HIV, certainly in this part of the world. And most of the studies in the meta-analysis that Freeman did involved heterosexuals, although several did include MSMs. And Renzi et al. in JID in 2003 did a large study looking at HSV2 as a risk factor for HIV acquisition. And they found that there was, in fact, a risk of acquiring HIV if you're HSV2 seroprevalent, and that was independent of recognised HSV2 lesions. And the risk of acquiring HIV was higher for the risk of acquiring HIV, yes, was higher for those who'd acquired HSV2 recently, that is for incident HSV2. Okay, we also know that the HIV viral load increases in those with HSV, and a study from sub-Saharan Africa showed that for people with both HIV and HSV2, there was a 0.3 log copies higher viral load than for those without HSV2, and the shedding rate is also related. When I mentioned screening, and Dominic's also mentioned it and said that he does screen or those with HIV for HSV2. When I talk about this, people say, well, how will these poor HIV-positive individuals cope with a diagnosis of HSV2? There's actually been a good paper recently in sexually transmitted infections that showed that most people with HIV cope very well indeed with a diagnosis of HSV2. They looked at 248 HIV-positive individuals, and 69% of those were HSV2 positive, and about 70% gave no history of genital herpes. They did 90 items, psychosocial and quality of life scales. They did those at enrolment, at 2 weeks after diagnosis, 3 months, 6 months, and they really found there was no difference in the quality of life and the psychosocial state between those who'd been recently diagnosed, past diagnosed, and those who are HSV2 seronegative. So in an HIV-positive population, the diagnosis of HSV2 is generally not a traumatic event. And then I hear about the exorbitant cost of screening, and I'm always amazed at that when those of us working in HIV order, viral load tests at $186 a pop without thinking about it, and the type-specific serology will cost in Queensland $14.90, and the Medicare rebate fee is $15.75. There are some indeterminate results, of course, that will require Western blot confirmation. We send them down to Westmead, and really that will increase the cost, obviously. But most HIV-positive MSMs will only require this testing once because they're going to come up positive at initial screening. We also test for CMV, we test for toxoplasma, which probably have far less relevance these days than does screening for HSV2. There will be some staff costs associated with giving the diagnosis, but I think overall the cost is not such a major issue when we're talking about this. And what about HSV1? Adrian's outlined very nicely what's happening in terms of HSV1, and it has been difficult to study the influence of HSV1 on HIV due to the high seroprevalence of HSV1 in many of the HIV-infected populations. But most studies have really shown no correlation between HSV1 and HIV acquisition, but as I said, that's been difficult to determine. Recent data from the HIM cohort, and I thank Andrew Grulich for this, do support a role for HSV1 in HIV acquisition. And baseline HSV1, but not HSV2, interestingly enough, seropositivity was associated with incident HIV in their study. So, in conclusion, I think screening for HSV1 and HSV2 should be encouraged for HIV-positive individuals. I don't think it's the most important test we will ever do for these individuals, but I think it is something that we can offer them. Screening for HSV1 and HSV2 should be considered, I think, for those who are at risk of acquiring HIV, particularly young gay guys or guys having lots of sexual partners and at high risk. The cost of screening is not particularly high, and I would say as a recommendation that yearly screening may be appropriate for people with HIV and at-risk individuals who are negative on initial serology, and most people with HIV will cope well with the diagnosis of HSV. Thank you.